Welcome to Chapter 6 of Essentials of Healthcare Finance, where we're talking about revenue determination. So there are three payment determination bases: cost, fee schedule, and price related. These three payment bases may have two different units of payment, either specific services or bundled services. Healthcare providers can control their revenue function in three ways: price setting, contract negotiation, and appropriate billing and coding measures. The three factors that influence pricing are desired net income, competitive position, and market structure. Other factors that influence pricing are market share, capital intensity, and payer mix. A sub-factor affecting pricing under the market structure umbrella is price elasticity. Products or services whose ultimate demand is strongly influenced by price are said to be price elastic. Healthcare services, while not immune from the pressures of price elasticity, are usually less affected than other products. The presence of health insurance has further insulated many of the effects of price in healthcare markets. Most businesses would like to operate in an environment in which significant barriers to entry exist to protect them from new competitors. Large capital investment and certificate of need regulations can prevent new healthcare providers from entering a market, as well as restrict growth for existing providers. Healthcare firms must set rates at levels sufficient to maintain their financial viability. Price setting must also recognize that some payers may pay values that are less than full or average cost. Prices must also reflect discounts from billed charges that may be granted to health plans or uninsured patients. And the last requirement that needs to be included in price setting is some factor for profit. Healthcare providers will with either tax-exempt or taxable status need some return to ensure their financial survival. Large write-offs or discounts to the charge-related payer base can and often do escalate prices to levels that are well above cost. The relationship between hospital and cost and hospital price has changed markedly during the period from 1996 to 2014. Payers and hospitals often assess the reasonableness of their prices based upon comparisons with similar hospitals and/or other hospitals in the same geographic region. Our learning objectives are to define basic methods of payment for healthcare firms, understand the general factors that influence pricing, define the basic healthcare pricing formula, determine if prices are defensible, and list some of the important considerations when negotiating a managed care contract. Alternative payment systems. Payment systems can be categorized by two dimensions: payment basis or unit of payment. For the payment basis, the basis of payment defines how the actual payment will be made. There are three primary methods. One is cost, two is on a fee schedule, for example, a DRG, or three, they're price related, example, it's 75% of billed charges. Unit of payment defines how the services provided are consolidated into an actual claim. There are two primary methods. One, specific services where individual items that are listed in a claim are paid, and two, bundled services where specific services listed in a claim are paid on some aggregated basis, such as a DRG or per diem. Table 6.1 shows the healthcare payment methods. You can see the unit of payment and the payment basis based on cost, fee schedule, and the price-related components. Factors that influence pricing include the establishment of CDM prices and the negotiation of managed care contracts. Three factors drive pricing policies: the desired net income, the competitive position, and the market structure. Setting your actual charge master prices. There are 4 factors that must be mathematically reflected in prices. Failure to incorporate these 4 factors will impact financial survival. The 4 elements of pricing are average costs, the losses on third-party fee schedule payments, Medicare, Medicaid, and other, the write-offs on billed charges for self-pay and for commercial, and what a reasonable return on investment is for sustainable growth. So here's a pricing example. Given the specified volumes, cost, desired profit, and other assumptions, what is the required charge per visit, i.e. the price? Given the specified volumes in the previous slide, of the cost, desired profit, and other assumptions, what is the required charge per visit, or the price? The general pricing formula that's being used is that price equals the average cost plus the required net income and loss on the fee schedule payers divided by the volume of charge payers divided by 1 minus the average discount experienced on charge payers. So as it applies to our example, the price equals $100 plus $5,000 plus $1,500 divided by 200 divided by 1 minus 0.55, which equals $294.44. Factors that tend to increase prices are increase in cost, government programs that pay less than cost, managed care plan fee schedules that do not pay at levels above cost, increases in required profit such as debt service obligation or capital replacement, reductions in charge-paying patients, and increases in uninsured patients. There are 2 generic ways of assessing whether charges are reasonable or not. One is the return on investment adequacy, and 2 is a comparison with other healthcare firms. A return on investment method with this example, it shows the return on investment equal to revenue minus cost divided by the investment. And the 3 issues that need to be answered is the ROI at this case hospital reasonable? Would you expect to have a return on investment that captures your cost plus your investment? And are costs at the case hospital reasonable? Well, that's, can be rather subjective. So diving down deep into that to determine that in quantitative measures may help by comparing to other hospitals, efficiency ratios, those types of things. And is the investment at the case hospital reasonable? Is it something that the community needs? As we continue to look at the reasonableness of cost with this case hospital example, we need to look at our cost assessment methodology. The first is the Medicare cost per discharge, which is the case mix index and the wage index adjusted, or the MCPD. Case mix index is simply a weighted system that measures the acuity of the patients that are in the hospital. And the significance of that is that the higher the acuity, the longer the length of stay, and the more consumption of resources, the higher the cost that it's going to be. You have one hospital who simply has some patients who are not feeling good sitting in a hospital bed on a medical floor versus a hospital who is doing a large number of heart transplants and liver transplants. Their acuity and their costs are going to be a lot different, so their reimbursement is going to look different. Their entire case mix is different. Number 2, the Medicare cost per outpatient claim is the relative weight and wage index adjusted, the Mcpc. So then the cost index is constructed by the following formula, with the hospital cost index equaling a percentage of inpatient revenue times the MCPD divided by the U.S. average, plus the percentage of outpatient revenue times the MCPC divided by the U.S. average. Let's take a look at how some of this shapes out in the next slides. Here, the Medicare cost per discharge based on the CMI and wage index that is adjusted shows the case hospital at $8,020. The state, in comparison, the state academic medical centers at $77.95 and the regional academic medical centers at $72.99. Here we see the cost per Medicare visit based on the relative weight and the wage index adjusted. Case hospitals at 60.34. State academic medical centers at 70.58. Regional academic medical center at 86.77. Showing that the cost per Medicare visit is much lower at the case hospital. The fixed asset turnover, the net revenue divided by net fixed assets, shows that the case hospital is at 2.8, state academic medical center at 2.3, regional academic medical center at 2.4. So what does that all mean? The summary of this case hospital example is this. It concludes that the case hospital is not realizing excessive profits. Costs at case hospital are consistent with expected values and are reasonable. Also, investment at case hospital is reasonable and not excessive. Therefore, the prices must be reasonable. The comparison of charges method, we can look at this case hospital example. The general methodology is to compare with similar hospitals and/or compare with hospitals in the same region. For the case hospital, we'll compare with all academic centers in California and compare with regional average for academic medical centers with cost of living adjusted. The hospital charge index in this example shows the case hospital at 187.1, the state academic medical center at 147.9, and the regional academic medical center at 132.4. The Medicare charge per discharge based on case mix index and wage index adjusted shows the case hospital at $56,104, state academic medical centers $48,275, and regional academic medical centers at $29,940. The average charge per APC based on relative weight and wage index adjusted. Case hospital is $235, state academic medical center at $346, and the regional academic medical center at $339. The Medicare inpatient DSH percentage average value is showing at case hospital at $8,020, the state academic medical center again at $77.95, and the regional academic medical center at $72.99. In any managed care contract, there are two critical elements. First, there's the payment schedule, which describes the basis of payment and actual payment fee schedules. Second, there is the actual contract language, which describes the administration of the contractual arrangement that determines how services are provided and paid. From most providers' perspectives, the key element in a managed care contract is the payment or compensation schedule. For hospitals, the predominant unit of payment for inpatient care is usually a per-day basis. Many hospital contracts have outliers or stop-loss provisions. This provision specifies that the hospital may pay on a basis other than per diem or case if charges exceed a specific limit. Many managed care contracts that provide for payment of claims on a discount from billed charges include rate increasing limit clauses. The price increase limit provision is intended to prevent a hospital from raising its prices beyond reasonable levels. Medical groups are often paid on a fee schedule basis with limited capitation arrangements sometimes being used. The fee schedules are usually by CPT and in some cases are directly related to Medicare's resource-based relative value scale payment system. There are 10 important areas of managed care contract language. One is to make sure to remove contract ambiguity, eliminate retroactive denials, establish a reasonable appeal process, define clean claims, remove most favored nation clauses, prohibit silent PPO arrangements, which is when a PPO takes the discount off of another network without actually belonging to that network. Include terms for outliers or technology-driven cost increases, establish the ability to recover payment after termination, and preserve the ability to be paid for services, and minimize health plan rate differentials. In summary, revenue generation is critical to financial solvency. Revenue generation is impacted by three areas: pricing, contract negotiation, and coding and billing. Inadequate payments by many government payers force healthcare providers to cost shift.